Hello everybody, my name is Lubberink. I'm a medical physicist at Uppsala University in Uppsala, Sweden, and I will be talking about our first experiences with deviceless data-driven gating and gallium-68 DOTATOC on a digital PET-CT scanner. As we all know, unlike CT, the acquisition of a whole body PET scan is quite slow. It takes generally 5 to 10 minutes on a modern scanner, either divided into separate bed positions or using a continuous flow. But irrespective of that, this scanning time is too long for a patient to be able to hold his or her breath, and that's why normally acquired static PET images will also always show respiratory motion artifacts like the ones you see on the image on the right hand side here. So we see the small lesions in the lower left lung that have been smeared out because of the respiratory motion. And there are several ways that we can take this motion into account when we reconstruct our PET images, and most of those are based on detection of the respiratory motion with an external device, like the one shown here on the left hand side, a respiratory motion platform RPM device by Varian. Which records motion of an object based on the patient's chest. Another option is, for example, to use surface scanning or to use a pressure-sensitive respiratory bellows device. And what the data from this device does is that it divides the acquired list-mode PET data into different phases across the respiratory cycle. And it has been shown, and this slide concerned FTG, but that correction for respiratory motion using this respiratory gating has a number of benefits, such as improved lesion detection, improved quantification, that is, we get higher SUV max values that we suppose are closest to the actual SUV values in the lesions. And improved staging accuracy, and of course this can benefit radiotherapy planning, because if we use gated treatment, we also want to use a gated PET image to draw our targets on. There are two options when we do respiratory gating, essentially. One is that we reconstruct every bin separately, so that we get a 4D PET scan. And this can then be combined by doing non-rigid co-registration of the different bins and sum them together, and then we get a non-moving image. And in GE language, that is called Q-freeze. The other option is to only reconstruct the end expiration quiescent phase, usually consisting of 50% of the total of the acquired data, and on GE scanners that is called Q-static. But you have to remember that we acquire in list mode, so all the original data is still there, and we can always go back and reconstruct a non-gated scan or change the parameters of our gating. So in terms of data acquisition, there is no difference between prospective and retrospective gating. It's always retrospective in a way, because we always have the list mode data to fall back on. So this is an example of that. For the conventional static reconstruction, we use all the data that we have available, whereas for the Q-static quiescent phase reconstruction, we only use the end expiration phase, covering about 50% of the total respiratory cycle. Now, this hardware-based respiratory gating is very cumbersome and hard to implement in a clinical workflow. So it is actually very rarely used routinely. And a question that has been asked for a long time: can we actually find the breathing waveform in the raw PET data without having to use an external device? And of course we can, otherwise I wouldn't be having this talk. And I'll try to give you an example of how that works. On the left hand side here you see a simulated PET image of a sphere that is bouncing up and down. And the motion of the sphere over time is shown by the graph on the lower right. Now, if we would put this sphere in the PET scanner, then the PET scanner would measure sinograms, and that's the one that we see here to the right of the sphere. So the sinogram of the sphere is if we look at it over time and make a new sinogram every half of a second, we see that it's dancing from the left to the right, corresponding to the bouncing of the sphere up and down. Now, data-driven gating, as it is implemented now in GE's MotionFree, uses principal component analysis, and what that essentially does is that it divides up the sinogram into components that explain the different variations in the data. And the component that you see here first, principal component 1, is the average of the total motion of the sinogram, which explains most of the data. Principal component 2 explains the largest variations actually in the motion. So when the sinogram is all the way to the left, it can be described as principal component 1 plus principal component 2. And when it's all the way to the right, it can be described as principal component 1 minus principal component 2. And we can make more of these principal components, and the further to the right you get, the more they describe just the small variations in the motion. And now we can actually express each of the sinograms in the time-dependent sinogram on the left here as a function of these 3 different principal components over time. And if we plot the time-dependent coefficients A, B, and C, then we get graphs that look like this, that show the contribution of each of these principal components over time to the time-dependent sinogram. And as you can already see here, the principal component 2 contribution to the total signal resembles very much the motion that we actually gave the sphere. Now the next step is to do a Fourier transform, which will tell us which frequencies that are present in these graphs that we see here. And if we do that, we get the curves at the bottom here. And the R values displayed here is the ratio between the peak in the frequency range that is likely caused by respiratory motion divided by all the signal that we find with higher frequencies than respiratory motion. So respiratory motion is assumed to be in the range of between 0.1 and 0.4 Hertz, which corresponds to 1 respiratory cycle every 2.5 to 10 seconds. And as you can see here, then it's of course principal component 2 that most likely describes here the respiratory motion. This slide shows some frequency graphs for actual patient data, and on the left hand side you see a principal component that actually describes respiratory motion, whereas on the right hand side one that does not. So data-driven respiratory gating tries to find a breathing signal in the raw data using principal component analysis in this case. The data is binned into 0.5 second sinograms and downsampled in X and Y directions, but not in Z direction, because it's in the Z direction that we expect most of the motion to occur. And if a waveform is found, quiescent phase gating is performed. So a quiescent phase image is reconstructed exactly as with external device gating. This can be done prospectively because it can be done very fast. The breathing waveform can be detected within 30 seconds, and the software will then automatically extend the scan time for that bed position so that we get the same number of counts in each bed position anyway, irrespective of whether we find a breathing signal or not. And this is based on a method first presented by Tielemans and others in 2011. Matthew Walker and colleagues in Oxford have done a lot of testing to validate this method. For example, here using a phantom that was moved inside the scanner using a driving waveform shown by the black line in the graph here on the right hand side. And as you can see, the motion detected by the respiratory motion platform and the data-driven gating is virtually the same. So the data-driven gating picks up the motion of this phantom very well, and this is actually one of the first patient images that was made with this technique. On the left-hand side, you see the image without gating. On the right-hand side, the image with data-driven gating, and as you can see, the smeared out lesion on the left-hand side in the liver looks much better on the right hand side, and we see an increase in standardized uptake value of almost 50% in this case. So if we go back to this figure, the next question is which R value is high enough so that we can assume that the waveform that we found actually represents respiratory motion. And to this end, the Oxford people looked at these waveforms and scored them with a score between 0 and 2, where 2 represented actual very likely respiratory motion and 0 no motion at all. And it turns out that for an R value of 15 or higher, all the waveforms resembled what would be expected of respiratory motion very well. So that is what made 15 the cutoff that is actually used in the MotionFree software. And they used a Discovery 710 scanner with a 15 centimeter field of view, actual field of view. And in their case, the R value was above 15 in 1.2 beds per patient on average. And those beds were then generally centered somewhere between 5 centimeter above the dome of the liver and 20 centimeter below the dome of the liver. On the Discovery MI scanner, with its 20 centimeter axial field of view, on average 1.3 beds per patient have an R value about above 0.15. So there's not a huge difference there when we extend the axial field of view of the scanner with 5 centimeters. So this is all for FDG. So how would this work for other traces in FDG? For example, the receptor ligand gallium-68 DOTATOC used in patients with neuroendocrine tumors has a much higher contrast between healthy organs and background, as you see on the lower right here, compared to FDG on the lower left. And we would expect that would affect its sensitivity of data-driven gating to respiratory motion. So we included so far about 30 patients in a study with gallium-68 DOTATOC. They each underwent a whole body scan on a Discovery MI 4-ring digital PET-CT scanner with a 20 centimeter field of view, and we use a 23% overlap between bed positions. And we scanned 2 minutes per bed position. Images were reconstructed using time-of-flight OSEM with 3 iterations, 16 subsets, and resolution recovery, plus a 3mm Gaussian pulse filter. And we use prospective data revision using MotionFree as it is now implemented on our scanner. And then performed quiescent phase gating. So we use Q-static to only reconstruct the quiescent phase part of the acquired data. And on this slide you see a first example there on the left hand side without any respiratory motion correction, and on the right hand side with MotionFree. And as you can see, the small lesions in the lower left lung were smeared out a lot without correction, but MotionFree actually showed them as much more spherical. There's a second lesion here, which after MotionFree suddenly appears next to this larger lesion in the liver. And if we look at the HOV values, then, for example, this very small lesion on the left-hand side in the images here showed an increase in HOV of about 33% in this case. Here's another example, which very clear motion artifacts on the left-hand side, which disappear when we do MotionFree. There was also a couple of patients where we actually found lesions after data-driven gating and MotionFree, which we did not see without motion correction. And these are 2 examples of that. There's 2 very small lesions in the liver in both of these that were not picked up by the reader without MotionFree, but were after MotionFree. This slide shows the distribution of the R values over the whole body across all patients. And as you can see, bed positions with R values over 15 were mostly just above and below the dome of the liver. In 6 out of 30 patients, MotionFree was not triggered, so there was no breathing signal detected. If we compare these results to the previously published results for FDG, we see that the range of bed positions at which motion is detected by MotionFree for gallium-68 DOTATOC is from about -30 to +10 centimeter relative to the dome of the liver, compared to the -25 to +5 centimeter for FDG. Again, remember that the graph on the left-hand side represents a 20 centimeter field of view, whereas the graph on the right-hand side represents a 15 centimeter field of view. But in general, it seems that we see motion over a slightly longer actual range with DOTATOC than we see with FDG. There was also a significant increase in HOV max when we compare no gating to data-driven gating. And to summarize these results, using the same threshold value for respiratory motion detection as that recommended for FDG, 15, motion was now detected on 1.8 beds per scan on average. And we can compare that to the 1.3 beds per scan detected using the same scanner for FDG. In those patients where MotionFree was triggered, we found 2.2 beds with motion on average. The increase in SUV was on average 25% with a range of -2 to plus 47%, and we saw a 21% average decrease in lesion volume using data-driven gating compared to doing no motion correction at all. So we find a higher sensitivity of data-driven gating for DOTATOC than for FDG, and we can use that in two ways. We can either use it and appreciate that we now have a better detection of respiratory motion, or what we could do is actually increase the R value a little bit to end up with the same number of bed positions as for FDG, to not unnecessarily increase the scan time that each patient spends in the scanner. So I'll show you a short video here of how this works in practice. On the left-hand side, you will see a patient that is being scanned with external device gating, and on the right-hand side, the same patient being scanned with deviceless data-driven gating using MotionFree. And as you can see on the right-hand side, about 50 seconds after the patient and the technologist enter the room, the scan can be started. Whereas on the left-hand side, you see that it takes about 5.5 minutes to actually set up the external device and start the scan. The total procedure using MotionFree will take about 17 minutes in this case. And when the scan with MotionFree on the right-hand side is finished here, the scan on the left-hand side is still ongoing and will take about 4.5 minutes more in total than the deviceless gating scan on the right-hand side. So there is some time gained there, but I think that's not explaining all of it. If you ask our technologists, then the hassle with external device gating actually takes much more time than these 4.5 minutes that were shown in this video. Next, we decided that we wanted to look at reproducibility of SUV values using MotionFree data-driven gating. So far we included 5 patients for that. They underwent a gallium-68 DOTATOC whole body scan with prospective MotionFree, starting at about 65 minutes after injection on average. And then when the whole body scan was finished, we asked the patient if we could scan the bed positions where a breathing signal was detected one more time. So that started after about 80 minutes after injection. And we looked at the SUV values both during both scans, both without gating and using MotionFree. And in both cases, we used 2 minutes of the available data. So the count statistics in the non-gated and MotionFree images are the same. As you can see here, the reproducibility of the non-gated images and the MotionFree images was actually fairly similar, with a mean difference between scans of 4.5% without gating and 4.1% with MotionFree. And as you can see, on average, all the values in scan 2 are a bit higher, but that is because the SUV of DOTATOC is still increasing at 65 minutes after injection. So the actual signal is not constant. Now there's a number of things that we have to consider when we use data-driven gating. First of all, breathing instructions. We don't do that, and probably it's not necessary. Do we trust this threshold all the time, or should it be checked? And I think we need more data to actually give an answer to that. But so far we haven't seen any situations where MotionFree was triggered where it should not have been. Do we want to do this prospectively or retrospectively? I think it works fairly well prospectively for us. And do we accept a slightly longer time of the patient in the scanner for gallium-68 DOTATOC with a slightly higher sensitivity of MotionFree, or do we want to use a higher threshold so that we don't have the patient in the scanner for a long time? So to summarize, device data-driven gating requires no additional setup time before, during, or after the scan. And it actually, for the first time, allows for routine implementation of respiratory gating in the clinical workflow. So for us, this is a first time that we're actually using this routinely now. And what we found in our work is that data-driven gating appears to be more sensitive for the respiratory gating signal for DOTATOC than it is for FTG. I'd like to acknowledge especially Jonathan Sigfridsson, Elin Lindström, and Eski Illan, who performed most of the work that I just presented. The PET physics group at Uppsala University and the staff at Uppsala University Hospital PET Center, and GE Healthcare for partly funding one of the PhD students involved in that work. Thank you for your attention.